a comprehensive weight loss lifestyle program and who have no contraindication, including no active cardiovascular disease, evaluate for obesity pharmacotherapy. And if their BMI is more than 35, they're suggesting to refer to bariatric surgery. All right. So this is what has been suggested for patients with obstructive sleep apnea, overweight, with obesity. What Eli Lilly did, they had this beautifully designed trial in patients with obstructive sleep apnea called SURMOUNT OSA. The SURMOUNT OSA was really to evaluate tirzepatide in participants moderate to severe obstructive sleep apnea and obesity, regardless of the CPAP use. So they actually had two studies, and this is the master protocol for two studies evaluating the effect of tirzepatide in patients with moderate to severe. So the upper side here is the study one. Those were the patients with obstructive sleep apnea, but they were not on CPAP. And in study two, they were patients with obstructive sleep apnea and obesity, but they were on CPAP therapy. And again, as we have shown from the previous studies, that the patients were randomized to receive the tirzepatide, and then they continued to escalate the dose on a weekly basis until they reached 10 or 15 milligrams, which is the maximum tolerated dose in this patient. So what they were looking at to evaluate the severity of the obstructive sleep apnea, to see if we are doing something to help those patients, as I explained just a while ago, is really we look at something called apnea-hypopnea index. So for study one, for those patients who were not in PAP therapy, you look at the apnea and hypopnea index decreased, and you have to go by minus. The higher the minus is better the result. So it's reduced from minus 4.8 to minus 27.4. And you can see it on the right side of the screen for those patients actually from minus 6 to minus 30. So what does that tell me? That the number of events, the number of apnea-hypopnea index is significantly improved, as you can see. Very interestingly, look at when the separation of the curves happen. It's almost happening on week 2. Look at the drop on this apnea-hypopnea index that has shown great results. And I'll be honest with you, we do see a lot of patients with obesity with different complications: diabetes, hypertension, heart failure, osteoarthritis, polycystic ovarian syndrome. The blessings and the happiness I have heard from patients with obstructive sleep apnea, I have never heard it from any other patient. It's a blessing, wa ni'mah, from a patient when they come and they tell me, Wallahi, doctor, I haven't slept for the last few years. Now I'm sleeping. Now I'm sleeping better. So really, I'm really glad that we have now such molecule that can help our patient. This is basically a secondary endpoint where basically it's the same thing, looking at the apnea index, comparing those tirzepatide maximum tolerated dose, either 10 or 15 milligrams versus the placebo. And you can see that it's a huge difference between them, clinically significant. And here you can see the percentage of people achieving more than 50% reduction. So they actually looked at people. What's the percentage of people achieving more than 50% reduction in the apnea and hypopnea index down at week 52? So look at those in study one, who those were not on CPAP therapy. We are talking about 62%. So 62% of your patients who have obstructive sleep apnea, so 6 out of 10 without CPAP therapy, are achieving 50% reduction in their apnea and hypopnea index. And you can see it, a better reduction, of course, if they were on CPAP therapy, as you can see on the right side of the screen. Up to half of the participants taking tirzepatide achieved the remission of obstructive sleep apnea or mild non-symptomatic obstructive sleep apnea. The guidance suggests that the treatment of mild obstructive sleep apnea, would they have the 5 or less than 15 apnea hypopnea with PAP therapy or other treatments, may not be necessary when patients are asymptomatic and do not have significant comorbidities. So look at what the guidance are telling us. For those patients who have mild obstructive sleep apnea, you can see there is a significant reduction on their apnea-hypopnea index. Let's go to the weight. And we have seen that with the SURMOUNT, SURPASS trials, but now let's see it in the SURMOUNT OSA trial. What's the percentage of weight reduction? On study 1, we're talking about 18%. On study 2, about 20% of weight loss happened for those who are on tirzepatide versus the placebo. The most frequent reported adverse reactions, I think I've shown this slide with every single trial I showed you, is around تقريبا 10 to 15%, mostly GI, and more generally mild to moderate, and occurred during the dose escalation period. Now, let's talk about a patient. So this gentleman has obstructive sleep apnea. He's 39 years old. He's an associate professor at the college. He does have a severe obesity, hypothyroidism, and obstructive sleep apnea. So let's talk about his tirzepatide journey. And this is one of the best patients I've had. And I will not, like, he is living a life, mashallah, tabarakallah, in a much healthier way now. And I'm going to tell you his story, what happened. So this is his journey. So he's 39. He's a college associate professor. He has a severe obesity after, like our previous patients, unsuccessful attempts of weight loss. He had previously been told that the medical treatment for obesity would be ineffective. Look at this. He has been told the treatment for his obesity would be ineffective because of his underlying hypothyroidism. And that he simply would have to live with his condition. His concerns were not cosmetic. Obesity has become a major barrier for his professional and personal life. So looking at history, he has hypothyroidism. He's on levothyroxine, 300 micrograms. He has pre-diabetes. His BMI is 58. He does have obstructive sleep apnea. He cannot share a room with his wife due to the severe snoring and apnea. He does have a non-restorative sleep, and he does have a daytime excessive sleep. And remember, this is a college professor, no? So he does have to give lectures and work in the college during the daytime. So when he does not sleep at night well, he's not performing well in his daytime. He does have difficulty in delivering lectures because of the fatigue. Midday sleeping, marked exercise intolerance, shortness of breath, and treadmill. He just came to me. He lost hope. He said, I was told I'm not going to lose weight. There's nothing can help me because I have hypothyroidism. On presentation, his weight was 160 kilograms. His BMI is 58. His hemoglobin A1C was 6.3. His waist circumference was 155 centimeter. His chest circumference is 130. One of the beautiful things about this patient that throughout his journey of tirzepatide, he was doing all the measurements by himself at home. His hip circumference was 160, and skeletal muscle mass was 38 kilograms, body fat of 60%. Look at down, multiple attempts to lose weight. Even they placed him on 1,500 calorie diet that we could not sustain. He's a gentleman. He's 40 years old. He's 160 kilograms. You cannot keep him on 1,500 calories diet. Like in his, because of the excessive hunger and the poor adherence, he's just going to lose hope and comes back. So if we think about this patient, this gentleman with an associate professor who's now presenting with this weight of 160 kilograms and morbid obesity, class 3 and more obesity, hemoglobin A1C of 6.3%, his concerns about the sleep, the functional limitation, remember that. If we think about what is the most important obesity-related complication requiring intervention, is it A, prediabetes, B, hypothyroidism, C, obstructive sleep apnea, D, the BMI of 58? And I agree. Since I'm presenting this after the the SURMOUNT OSA, I'm pretty sure that all of you agree that really the thing that we need to focus with this gentleman who's not able to function properly during the daytime is to focus on obstructive sleep apnea. So all are important, but the most immediate burden is really the sleep, disordered breathing, disrupting restorative sleep, the cognition, the work productivity the next day, and so on. Now the question for you, does underlying hypothyroidism make this patient a poor candidate for obesity pharmacotherapy. Because this was this was what's told to the patient. This patient has been on a BMI of 58, and he was told that no, he cannot take incretin therapy because of the hypothyroidism. Alhamdulillah, majority of you are saying no, which is B, and I agree. Of course not. Hypothyroidism is often blamed as obesity treatment failure, but we have to remember, adequately treated hypothyroidism is not a contraindication for obesity pharmacotherapy, and it should not delay the evidence-based treatment. So what did we do with this gentleman? Comprehensive obesity management program was initiated. And I'll say it, it's not me, it's not tirzepatide. The patient himself had the ability to work through this closely with me, with the dietitian, with the educator, with the gym trainer to achieve it a better. Tirzepatide with gradual dose escalation, we have reached the 15 milligram. Dietitian guided therapy, regular clinic visit. This is not a gentleman where I say, you know what, I'm going to give you the dose because I see this a lot. I give you the dose and I'll see you back in 6 months. No, this gentleman needs to be seen in the clinic every 6 to 8 weeks. You need to check his weight. You need to check his labs if needed, because he might need adjustment in the levothyroxine therapy. You need to make sure that he is following the exercise program and his calorie intake is being adjusted. This is not just the simple obesity to be just, just take the medication or go away. As the body weight fall, for the first time in years, a structured exercise becomes achievable. This gentleman, wallahi, I still remember, on the first visit when he came to my clinic, he's younger than me. He's not able to walk through the door. All right. Throughout the time, what we have seen with the structured program, we have seen improved satiety, better adherence to the nutritional recommendation, because now he lost weight, so he's able to move around. He has better increase in physical activity and exercise tolerance. So what do you think is going to improve first during his substantial weight loss reduction? I'm going to show you his numbers at the end. What would improve? Hemoglobin A1C, obstructive sleep apnea, the exercise tolerance, or all of the above? So I agree with all of the above, but what the patient actually noticed is really the obstructive sleep apnea. The first thing he noticed that he's able to sleep better in the same room with his wife. These are his numbers 2 years down the road, okay? We started with a weight of 160, BMI of 58. 2 years down the road, his weight is 104 and BMI of 38. Look at his measurements, looking at the waist circumference from 155 to 113, the chest from 130 to 111, the hip from 160 to 121, the body fat from 60 to 46, the skeletal muscle mass from 38 to 32, the A1C from 6.3 to 4.9, and the levothyroxine dose was reduced along the way from 300 to 150 micrograms. Now, looking at these numbers, the last time I also saw this patient, he actually achieved below 100. I'll tell you what happened with him. Which of the following represent the most clinically meaningful outcome? Is it the 56 kilogram weight loss? Is it the reduction in the waist circumference? Is it the reduction in the levothyroxine requirement? Is it the resolution of the sleep apnea? For us, for me as an endocrinologist, is really the weight loss. But I think reduction in waist circumference is important for this patient since he's measuring. Like in resolution of sleep apnea symptoms was one of the things that this patient mentioned. He said, "Doctor, for years I'm not able to sleep in the same room with my wife." He was literally tearful when he was saying that. So the functional outcome, the complete resolution of sleep apnea, the restoration of normal quality of sleep, the improve in energy, the improve in teaching performance, he returned to his regular exercise. MashaAllah, tabarakallah, MashaAllah, tabarakallah, Allah yahfadhu. He completed the Medina Marathon 3 times last year. He completed the marathon 3 times last year. This is the gentleman who started with 160 kilograms. And of course, alhamdulillah, he got promoted from associate to full professor at the college. So what was actually treated in his case? Is it the prediabetes, is it the obesity, the functional disabilities, is it the sleep apnea? I think the answer is all of the above. We have treated all those things. When we treat obesity, we are treating multiple diseases. So what are the key learning points here? I'm at the end of my slides. You can really type in your questions if they were not answered during the presentation, because we'll have some time for the discussion. Severe obesity should be treated as a chronic disease, regardless of coexisting hypothyroidism. Adequately treated hypothyroidism is not a reason to withhold obesity pharmacotherapy. Benefits extended for beyond weight loss. Remember those 3 cases I presented. Did we focus on the weight loss alone? No. We're talking about functional performance. We're talking about sleep ability. We're talking about promotions that being done at work. Successful treatment requires continuous adjustment. So this is a key. You cannot just give medication to the patient and just say them, I'll see you back next month. The way I do it, the patients get scheduled in the clinic before they leave. They know when their follow-up is with me and the dietitian before they leave. What's the take-home message? Severe obesity can be successfully treated with a comprehensive multidisciplinary approach. Do not withhold obesity pharmacotherapy because the patient has hypothyroidism. Significant weight loss can dramatically improve or resolve obesity-related sleep apnea. View weight loss as a mean to improve health, not as a function. Health and function, not as a final goal. So it's not only weight loss, but also look at the patient's function and the patient's health. The most meaningful outcome here was not really the 56 kilograms that was lost. It was going from unable to walk on a treadmill to running a marathon and thriving professionally. This was really the outcome that this patient actually achieved. Before I close my presentation, few slides about how to start and continue the tirzepatide. Usually we have 6 different doses. The starting dose is 2.5 milligram, and then 4 weeks down the road, increase it to 5 milligram. Then if you need to achieve a better treatment goal in terms of the patient is able to tolerate, you can escalate the dose to 7.5, followed by 10, followed by 2.5, 12.5, followed by 15. But the key thing to remember that the patient need to stay on each dose at least for 4 weeks before increasing to the next dose. And this is very important. Yes, I do refer my patients to the clinical dietitian. Lakin, I think our patients deserve some education from us. So it's always remember to discuss with our patient to eat smaller meals, suggest that they split their 3 daily meals into 4 or more smaller meals. Avoid the fatty food. When the patient texts me complaining of GI or severe nausea, the first thing I ask them, what did they eat? Stop eating when they feel full. Patients have this in their mind. No, they are used to eat 20 spoons of rice. They are used to eat 2 sandwiches. No, they have to be told because of the medication, they are going to feel full earlier. So they have to stop eating. They have to think about what is getting there. I asked them, it's okay, you can keep your 2 sandwiches, but eat one and keep the next for after 2 hours. And always, of course, specifically during the dose escalation period, always try the, I ask them to eat the bland foods. Usually, I refer them to the dietitian. They will sit down with them with a detailed explanation of all of this. And of course, also we are in summer, so it's always important to remember that we have to avoid dehydration by drinking plenty of water. Helpful tips on starting tirzepatide for people living with obesity. Talk to your patients about the safety profile. Discuss the side effects such as the nausea, diarrhea, or vomiting. I think it's our job to discuss that. As I said earlier, eating smaller meals, stop eating when they feel full. Encourage the patients to continue to drink plenty of water and eat healthy meals to ensure that they meet their needs for protein, micronutrients, fiber, and fluids. Recommend that pregnant patients and women of childbearing potential should use the contraception. Do not using the contraception should not initiate or continue treatment with tirzepatide. So those who are in the childbearing age, and they should, and they are not on contraception, they should not use the tirzepatide. So across all cases today, what we have achieved, the ultimate goal of obesity management is not simply reducing the weight. It's about restoring health, confidence, function, and quality of life. By this, I would like to thank you very much. Thank you very much for your attention. And I'm more than happy to take any questions that has not been answered during the presentation.
Thanks a lot, Dr. Naweed, for such a great and informative session throughout the past 2 hours. It is really reflecting not only the clinical trials, but also the disease itself as a portfolio disease with diabetes, obesity, obstructive sleep apnea today. And most importantly, the feedback you are sharing by your patients. So truly thanks for this. From what you just recalled, a lot of benefits has been reach out to the patients, not only in terms of weight management and diabetes or OSA improvement, but also the quality of life behind that. Patient not doing anything or struggling in doing the normal things to a patient that is finalizing more than 3 marathons. So this is really inspiring, mashallah, tabarak ar-Rahman. And thanks to you for your time, for sharing this clinical experience. I would like to ask all of our attendees to list all their questions to Dr. Naweed so we can address it all. If you allow me to start to take the questions that has been already received throughout the presentation, we do have one of question, actually not only one, we do have a couple of questions asking about the same endpoint. What are the long-term plans for patients undergoing life changes and weight loss medications in general, not only in Monjaro, in general? What is the ultimate objective goal for those patients in the long-term run?
So the way I look at this, thank you, Manar, for your comment, first of all. The way I look at this, the long-term goal, as I explained it to you in the cases, is really, I think we are only focusing on a percentage of weight loss or the number of kilograms or that. No, I keep saying that. I think it's not about weight loss, it's about health gain. So the long-term plan is to gain health. When I see someone is sleeping better, exercising in a much better way, we're talking about marathon here, is someone who used to be 160 kilograms, got promoted in his job, doing much better functionally, metabolically, much lower doses on other medications. This is my long-term gain. This is what I want to achieve. And really, it's not, I know for the trials, they look at the numbers, the percentage of the weight loss, but I think we are going to an era, we're not going to look at that anymore. We are talking about health gain more than a weight loss.
That's crystal clear. And also, there is a lot of questions asking about the recommendation between pharmacological therapies versus surgeries. Specifically, when you mentioned for us the third case, which is about obstructive sleep apnea and a patient who cannot walk around a lot, but he had more than 3 marathons, mashallah, tabarak rahman. So the questions usually raised in the chat box about when to decide whether to go with pharmacological therapy or bariatric surgeries, and what is your guidance in between?
So this is a very nice question for a patient with obesity of a BMI of 50. Believe it or not, for the first 3 visits for this patient, that has been discussed. That has been, I asked him to go and go to the surgeon, go to different surgeons. The patient completely refused. He does not want to go for surgery. All right. This is something we really need to offer to our patient. It's nothing against the bariatric surgery. I think I totally agree that the bariatric surgery still plays a role in a very good percentage of our patients with obesity. And usually we offer them this when it's needed. So for this particular patient, yes, I did. I not only did it once, I did it twice and thrice, but he completely refused ever to meet the surgeon. So this is his choice, and I think it was a good choice.
Alhamdulillah. And that's really good that we are talking in an era where there is optionalities between solutions for those patients, either with to go with surgery or either to go with pharmacological therapy in conjunction with the medical decision. Also related to that, a couple of questions we're asking about the dose escalation or escalation, as well as the tolerability. So I will combine it all in one question based on tirzepatide label and all the trials. What is the best approach for reaching out to the maximum tolerated dose for the patients?
So the way I do it is that I schedule the follow-up with the patient once they are escalated to the next dose. This is my practice.
Great.
So let's assume that the patient started on 2.5. I do not usually see them when they are at 2.5. Usually on 2.5 throughout the 2.5, usually is the clinical dietitian and the educator are following up with the patient. I usually schedule a follow-up when they are on 5 milligram. So once they are on 5 milligram and they're week 6, week 7, usually this is the time when I see them. I evaluate their symptoms. I evaluate how much food they are able to eat, how much exercise they are doing, how good they are sleeping, what's the percentage of weight loss that happened. And based on all these informations that in front of me, either clinically or lab-wise, I will decide that if I can escalate the dose further or not. We understand that when we do the slower escalation in some of the patients who experience the nausea and GI upset in a severe way, that is going to help them to avoid this GI upset. So a slower escalation is always possible. So what happens, Manar, is always we do receive, and I have right now, I have a lot of emails and messages from patients like, I'm on 5, what should I go next? I cannot answer this question without seeing the patient. I
Yeah,
really cannot answer this question without evaluating the patient
true.
in the clinic, either virtually or face-to-face, but the patient needs to be seen also by dietitian at the same time. So this is the way I do it,
Wonderful. So I think safety and tolerability
of course.
would make a lot of differences in here. And also, we do have a question about the contraindication with Monjaro or tirzepatide use.
So there are those patients who had pancreatitis. This is a contraindication to use Manjaro on them. And of course, on the label is really the medullary thyroid cancer, which the receptors are not there in the human thyroid, but the cancer itself is extremely rare. So for me as an endocrinologist over the last 15 years, I'll say that I've only seen 5 cases of medullary thyroid cancer and MEN that runs in the family. And this is in the label that this patient, if they have obesity, it's contraindicated, but I haven't seen a patient in actual practice presenting with MEN, medullary thyroid cancer, who needed the treatment. The other thing to remember is those receptors were on rodents based on rodent studies, not human studies. So these were the 2 major contraindications I could think of.
Wonderful, that's great. And there's 2 questions about the same point, which is, do you see any risks related to Monjaro with vision or optic neuropathy?
Uh, we have looked into that. Actually, there are many studies that have shown it's mostly has not proven a causality. It's not a cause. Not only tirzepatide or semaglutide, but it's not a cause. It's an association, and it has not been proven to the point that is that we should talk to our patients about this, saying that it is because of the medication. Because when we looked at those patients who actually had this NINO or the non-ischemic blindness, those patients were diabetic patients. Majority of them were fully controlled, but it was not clearly, strongly caused. We cannot say it is because of the medication, as far as I understand from the available evidence, at least.
Exactly. And we do have a question here related to the doses. I know we already covered the doses, but this is critical also to be addressed. So, is this same reduction in body weight with every dose, or a different weight within different doses?
Yeah, it's a very nice question, and I also wanted to look to answer this question. Hopefully, inshallah, I'll be able to do that my study on my own to look at which
MashaAllah,
doses
تبارك.
causes which how much percentage of weight reduction. But honestly, I don't look at it like if it's not for the research purposes, I don't look at it this way. Okay, I look at I'm gonna say it's a health gain. So the problem is, and it's an expensive medication, I have to say this. So the patient look at how many kilograms per week they're losing. So it's not like this. So I keep explaining to the patient that, you look at the total benefit. I look at the pre-Monjaro weight, all right? And I look at how many months you've been down the road, okay? And where you have achieved. This is the total percentage. Sometimes patients say, I lost 10 kilograms the first 3 months, then I only lost 4 kilograms. Yes, this is the metabolic adaptation. Your body is still fighting despite being on tirzepatide. We cannot, overcome the biology of our body. We always have to go back and review what we eat. Wallahi, and believe it or not, when I dig into the causes when patients actually gets their weight stable, they're not able to lose that further amount of weight. We find anxiety, we find insomnia, we find,
Yeah,
anemia. And there are many other causes that we cannot, we can think of that is actually causing this, regardless of the metabolic adaptation. So it's always good to go back to the basics and take a good history and examine our patients, review the lab data, and think about outside the box why these patients aren't actually losing the weight. I've seen patients, when they started to sleep better, they started to lose weight. And we have seen this with the data from OSA Surmount. The OSA
exactly.
Surmount was not only about the apnea hypoapnea index, it was about when the patients sleep better, they lost weight. And this is why if I go back to the slide of the OSA results, in terms of the weight loss. So look at the study too for those patients who were on CPAP. So probably those who were CPAP, they were sleeping better. So you still see, I think, a little bit of better percentage of weight loss in the population 2 versus population 1 in those who are not CPAP. So take this back to our patients who are awake the whole night, who are eating the whole night, صح? And they're not sleeping at night. They have insomnia, they have anxiety. There are other causes for them to gain weight. The Monjaro has nothing to do with it. So we have to think outside the box.
Exactly. And also, at the beginning of the meeting, we received a question about patient with obesity and obstructive sleep apnea, and they do have end renal stages or yeah, end renal impairments. So, do you prefer to use with them Monjaro, or do
Yes,
you prefer
yes.
to be
It's
cautious with them?
we understand from the pharmacokinetics it's totally fine that there is no dose adjustment, and this was clearly mentioned on the label, the Saudi label as well.
Wonderful. Also, one point related to that specific population, a lot of trials has already included patient with end renal or end stages of renal impairments. So, alhamdulillah, specifically for type 2 diabetes, it has been included in the study as a big population nowadays. Um, Also, there is two questions related to the vitamin supplements and the general, let's say, general guidance for the patients whenever they will start on Manjaro. So specifically for the vitamin supplement, do you prefer, for example, to prescribe something with those patients alongside with Manjaro?
Wait, I'm going to answer this in a bit, but let me go back to the patients with end-stage disease. One precaution I think we have to think about when we see patients with end-stage renal disease, because of the uremia, they are at high risk for gastroparesis. So for those patients, I will not go in terms like very quickly in terms of the dose escalation because they are in dialysis. They are already going through this cycle of nausea and vomiting, which is part
Exactly.
of their disease. and they might have gastroparesis. So we really have to be extremely careful in this particular group of patients. It's not that the tirzepatide is contraindicated. No, it's actually approved in those patients. Like we have to be careful the way we escalate the dose in
Doses.
this group of patients. And this is why
Exactly.
training the dietitians who are in the dialysis unit is extremely important. And this is what I did, at least in the dialysis center I practiced.
MashaAllah. That's
For the
really
second
great.
question, what is the most important vitamin? Usually the way I do this is, before we start the medication, usually we do have labs. And based on what I see in iron deficiency, I usually replace that to the patient from the beginning. There is no guidance, and I know there is so much to see on social media platforms that these are the Monjaro vitamins,
Mm,
like combination of like 10 different supplements the patient needs to take to avoid the whatever we call them, the face,
the hair
the
loss.
hole, yeah, all those things. I said there's no benefit, no clear evidence for this. All right. I think the only thing you need to do is replace what you need. And for me, is to go and exercise is much better than taking 10 different supplements. Sleep better is much better than taking 10 different supplements. I usually do the vitamin D, maybe because I'm an endocrinologist. I like to use vitamin D a lot, uh, because most of us are not being exposed to the sun, and we do have a very high percentage of vitamin D deficiency in our population locally. And uh, I just give them the maintenance dose based on their vitamin D levels. Then let's say this patient has, before even taking the tirzepatide, they have iron deficiency. They have, so I usually replace that along with the tirzepatide. And sometimes I replace and wait and then start the tirzepatide later on.
That's super clear. And I believe also vitamin D is somehow linked in some of the studies with obesity. So it's really, I truly love the exercise of doing vitamin D insurance or vitamin D, ensuring that the patient does not have any deficiencies in vitamin D. Um, there is a question related to um, changing from another GLP to Manjaro. So let's imagine a diabetes patient or obesity patient who was on another GLP-1. So do you recommend shifting immediately? Do you recommend a washout period? What is your
No,
guidance here?
there is no washout period. It should be like, let's assume your patients are on semaglutide. So 1 week after the last dose, you can start the tirzepatide. And the thing to remember here is, this is the most important thing, is when you started the tirzepatide, do not jump to a higher doses. You always have to start with 2.5 milligrams.
Wonderful. And there is a great question specifically about diabetes patient. So if your patient who is diabetic and started on Manjaro, by when you feel, for example, la samah Allah, uh, you are afraid about severe reduction of uh, blood glucose level or A1C, do you interfere sometimes or do you see it frequently?
So hypoglycemia is not something that usually we experience with incretin therapy, unless the patient stopped eating completely now. So, and
صح.
this is the advice usually we give our patients, that when we start the tirzepatide, that they usually need to eat multiple times a day, and they need to eat and get enough calories. So this is very important. Number two is the there is always this concern since the diabetes medication, because we are coming from an era of sulfonylureas and insulin, and anything that's related to diabetes is going to cause hypoglycemia, and incretins do not work this way. So they are glucose-centric. They will not increase. They will not increase the insulin release. They will not stimulate the insulin release from the pancreas unless the patient's glucose values are high. So if the patient's glucose values are stable, then there is no need. There'll be very low risk of hypoglycemia. I have not seen this I've been doing tirzepatide with my diabetic patients and obese patients for the last at least 2.5 years. I haven't seen a single case of hypoglycemia.
Alhamdulillah. That's really good to hear. And I will end up with two more questions because of the time. So, one of the questions is related about acute pancreatitis. If the patient already have acute pancreatitis and has been treated before starting Monjaro, would that be considered as a contraindication for starting Monjaro?
One thing I would add this, please confirm that, because what I see when the patients comes to me, they say, well, they visited ER and they were told and البنكرياس ملتهب, they had acute
Mm.
pancreatitis. The thing I do is I ask them to go back to the ER, bring me the CT scan report and the labs. And in those 3 patients I did, it was not an acute pancreatitis.
Oh, oh,
So just,
oh,
if possible, confirming, because patients, you'll say, والله يعني قالوا لي البنكرياس ملتهب, and
صح, an acute phase in the
yeah,
ER.
yeah. So so you really have to confirm it, and I understand it's very challenging because different hospitals, different medical record, not everything is electronic, but we are getting better with this, alhamdulillah.
Wonderful. And there is one of question that is keeping to be asked within the chat. I know you already thankfully answered it, but due to the importance of this question, let's just address it once again. Is Monjaro to be utilized as a long-term treatment for the patient with obesity, obstructive sleep apnea, or diabetes?
I think
Uh,
this slide answers this,
yeah, thanks
yeah.
for returning back to the slide. Yeah.
Yeah. So, يعني, uh, the thing is, we have to remember it's a chronic disease. It's a lifelong disease. And honestly, والله يا منار, يعني, when you are treating one disease that is causing 10 other diseases, I'm not sure why we need to stop the treatment for this. Again, remember, we will never stop a treatment for thyroid. We will never stop the treatment for diabetes. We will never stop the treatment for hypertension. Why? Because we are considering those as a chronic diseases. Obesity is a chronic disease. This is number one. Now, I understand it's a little bit challenging for women with a childbearing age, and I totally agree it is very challenging for such group of patients. And this is why we have to have more effort with those patients with structured exercise program, better education, better diet plans, along with having improving their awareness about the correct awareness about obesity and obesity treatment, which we lack locally. Because you can see there is a lot of misconceptions happening throughout the media, and the patients will walk in like because I hear this a lot, I know what they're gonna say. I know and I even know where the source is from. So I know it's very challenging, and but majority of our patients, I can say at least in the last 1 year, especially with the sermon, I usually keep the slide on my desktop. It's there. It's my desktop. So I show it to the patient. I say, when you stop your medication, I'm going to continue. You continue. Those patients continue. They actually continue to have lifestyle program, but they gained 14% back. The question that I don't know the answer to yet, if they stop, are they going to go back to their previous weight down the road? For example, 5 years, 10 years down the road, what's going to happen? But I think we are living in an era where there is more and more data coming in, and I'm collecting my own. So we'll see what's going to happen in the future. So it's a chronic disease that's going to require long-term treatment.
That's really great. And between all the chats that we do have it here, maybe more than 50% of the chats are really thanking you, Dr. Naweed, for your
Like,
time, your effort, and for sharing such real cases. Honestly speaking, from someone who has been working on Manjaro since was it launched, I truly enjoyed whenever I feel that there is an impact toward the patient, the clinical cases, the implication and the quality of life. And all of those has been tackled really well throughout the session. I truly enjoyed those 2 hours. I didn't feel it aslan, alhamdulillah. Yani. So truly thank you, Dr. Naweed, on this.
I
If you would
enjoyed
like to.
presenting, and I'm really glad. And I always like my last words would be really, I have to, I understand that the patients and the physicians like to talk about numbers. And I will say just think about the health gain, not only the weight loss for our patients.
Really inspiring, truly. Thank you so much, Dr. Naweed, and special thanks for your time and effort you have that throughout weeks to conduct such a great lecture at today. So thanks really for this, and I would like to thank our audience. I think we reached more than 390 HCPs who were attended, mashallah, tabarakallah, from 9 p.m. to 11 p.m. That's really great and reflecting how interesting this talk was. So truly thank you, Dr. Nawi, and truly thank you for all the audience who joined us. Special thanks to Virtual Medical Academy for having us today with Dr. Naweed and with the audience. Among all those cases, all those learnings, I truly enjoyed it. Thanks truly a lot. If you'd like to have any comments before we close, feel free.
No, thank you very much, Manal, for your continuous support, for making our patients' life better. And I will say one last thing, regarding the management of obesity is a team approach. It's not only Dr. Naweed. If my patients are improving, it is because of Eli Lilly, it's because of me, it's because of the medical team I work with, my educator, my dietitian, the education that goes beyond the scene, it's unbelievable. So it's not only because we do see a lot of our patients just buying the medication and taking on their own, and I think this is not going to help anyone, neither the system, neither the patient, neither the physician. So I think the key here is obesity is a medicine itself. We are learning every day. We are getting better at it, and we are living in a very exciting era. And we are hoping to see more and more, inshallah, in the soon future, bismillah. One day, inshallah, we will not be talking about HbA1c anymore, hopefully.
يا رب يا رب بإذن الله يا رب يا كريم الله يسمع منك. Thanks a lot, Dr. Naweed. Thanks again to Visual Medical Academy and for